For the sake of schedule tightness, I would like to ask a permission to switch the sequence of the speaker. Dr. Kurumisawa would like to speak in the first person today. This is my announcement, so thank you very much for understanding. We have around 10 minutes for each patient and 1 or 2 minutes for asking a discussion. I think I would like to start now. Dr. Kurumisawa, please, you are the first one. You're going to talk about the comparison between bilateral ITA in the short-term result in Lampang Hospital, please.
Okay, I'm a Japanese fellow in Lampang Hospital, and today my topic is a comparison between bilateral and single internal mammary artery bypass grafting, a short time result. How to move to next slide? Just okay. Oh, this one. Thank you. It's confused. I mean that. Yes. How to? Proceed. It's back. Okay. Okay. Sorry. There is a strong evidence from several observation studies that bilateral IMA CABG is more long-term survival advantage compared to single internal mammary CABG. However, BIMA grafting has not been commonly used because BIMA CABG is technically more challenging, and there are some concerns such as a longer operation time and increasing the risk of early mortality and morbidity. That is why we investigate the safety of bilateral IMA grafting about short-term results in our institution. We have retrospectively reviewed 101 patients who underwent isolated CABG with at least one IMA use between January 2019 to July 2019 in our institution. Patients were divided into two groups according to single IMA use or bilateral IMA use. This table is patient background, age, sex, height and weight, Euro score and stasis score, and ejectional fraction are no differences between two groups. Associated diseases are also no differences between two groups. Interoperatively, bilateral IMA use group was significantly longer operation time and graft harvesting time. Composite graft use ratio was higher in bilateral IMA use group. There was no difference in the number of anastomosis. Post-operatively, there was no significant differences in hospital mortality, in-hospital morbidity, and length of hospital stay. Cause of morbidity had also no differences between two groups. Generally, intraoperative concerns about using bilateral IMA are long operation time and harvesting time. Indeed, our results showed significantly long operation time and harvesting time in bilateral IMA use group. Another intraoperative concern is reduced conduit length. For getting longer length of IMA, we harvested IMA with skeletonized fashion using harmonic scalpel, and we aggressively used composite graft with radial artery. Actually, composite graft use was higher in bilateral IMA group. As a result, number of grafting has no significant difference between two groups. And generally, post-operative concerns about using bilateral IMA have increased early mortality and morbidity, especially deep sternal wound infection. Our strategies are schedulized harvesting, which is better for preserving blood flow to sternum, and high ratio of off-pump CABG, which is effective for preventing the suppression of the immune function. While longer operation time required for bilateral IMA, early post-operative results were not different between single IMA and bilateral IMA. The use of bilateral IMA graft is feasible on routinely basis. Thank you very much.
I want to ask the question from the audience. Do you have? Dr. Amman, please.
So in case of bilateral IMA, the composite graft or in situ graft, which one is more better in outcome? Do you have any studies like this?
Sorry, composite graft or?
In situ graft, I mean, you make it Y with the RIMA and the LED, or make it in as it is, I mean pedicle, RIMA and LIMA separate. You got my question? You put the bilateral IMA.
Yes, yes.
As it is, or you put it as a Y graft on the LED and the different, make it a Y with LIMA and RIMA, then put it as a graft.
You mean outcome in terms of morbidity and mortality?
Mortality, yes.
No, I haven't analyzed this study about it.
Okay.
Sorry.
If there's no more question, thank you very much, Dr. Kurmisawa.
Thank you very much.
We move on to next speaker, Dr. Chun Pan. Dr. Chun Pan has two topics. Now he's not present here, so we move on to next. Dr. Arif Ahmed Mohidin. He's going to talk about early outcome of surgical repair of post-MI ventricular septal rupture. Yeah, please. Dr. Chun Pan did not come at this moment, so switch the slide, please.
Honorable chairpersons and learned audience, good morning. It's an honor and privilege for me to present my presentation on this prestigious event of ASCVTS 2020 at Chiang Mai. As said by Steve Jobs on his return to iPhone in 1997, deciding what not to do is as important as deciding what to do. And it also true in our scenario as a cardiac surgeons while taking decision for surgical repair for post-MI VSR, whether we should do it now or wait for some times. And we are not sure whether we will be able to save the life of that patient. As we all know, ventricular septal rupture is an opening in the ventricular septum resulting from rupture of an acutely infarcted myocardium. It is one of the rare but lethal structure complications following MI. And in pre-thrombolytic era, the VSR incidence was about 1 to 2% after AMI presentation, but it reduced down to 0.17 to 0.31% as the reperfusion therapies become the standard of care these days. And in about 60% cases, the VSR is located in the apical or anterior septum, resulting from a transmural acute anterior MI. And around 20 to 40% cases is located in the posterior or basal septum, mostly due to inferior MI. And while we talking about the treatment modalities, this figure taken from Paulson et al. From Annals of Thoracic Surgery, they have shown that out of their 64 patients, 19 patients were treated with only medical management, and none of them survived beyond 21 days. But the 30 days operative mortality was less than 30% in surgically treated patient. And till to date, the surgery is still the treatment of choice for post-MI ventricular septal rupture. But the timing of the surgery is very important while taking the decision. And this figure taken from European Heart Journal, they have showed the reported 30 days mortality for VSR with immediate surgical management or at various time point of delayed intervention. As you can see, if the surgery is attempted within first 7 days, the operative mortality is as high as 54%. And if the surgery is done from 8 to 21 days, the mortality reduced down to around 30%. And if elective surgery can be done beyond 21 days, the mortality reduced down to less than 10%. And even in GUSTO-1 trial, they have also showed that the operative mortality is as high as 47% when attempted surgery within the first week. But if no surgery or percutaneous closure attempted, the mortality is as high as 94%. And these days, they are also attempting percutaneous closure in various cases, but it also has a very high operative mortality, and it is almost about 88% when attempted within first 3 days, but it reduced down to around 42% when percutaneous closure is attempted between 4 to 27 days. So although surgical mortality is high, even the non-surgical mortality is higher. So we'd like to try for the surgical mortality. As that time goes on, the mortality reduced down. So we try to attempt to do some medical management and defer the surgery for the time being by using some afterload reducing agent like GTN or SNP, or even we can use mechanical circulatory support like IABP, which will reduce the afterload, increase perfusion pressure, and decrease the workload of the heart, which will buy us some time. And even in some centers, they are using ECMO to buy some time to do surgery, which will help us to differentiate between the viable and non-viable myocardium and help us to give a better survival rate. And we have done, in order to find out outcome in our center, we have done a retrospective analysis of our 10 consecutive patients who were operated between March 2017 to September 2019 at our department in order to find out the in-hospital outcome of surgical repair of ventricular septal rupture. And all the data were analyzed using appropriate statistical tools. And our method of surgical repair was, treatment was going through the left ventriculotomy through the infarcted myocardium, 2 centimeter away from the LAD, and putting an adequate size Dacron patch on the LV side of the septum, and pledgeted proline stitch in the RV side away from the edge of the myocardium, and pledget putting on the RV side of the septum. And they were securely tightened and placed. And LV was closed through the interrupted proline using, going through the strip of failed myocardium and the Dacron patch, and they are reinforced by continuous Prolin suture. And the results was, out of this 10 patients, we lost 3 patients and 7 patients were survived. The mean age in the survival group was about 55 years, and non-survival group, it was 50 years, which was not, there was no significant difference between that group. Most of the patients in both groups were diabetic, hypertensive, and dyslipidemic. Preoperative EF was slightly higher in alive patient. It was 43%, and in non-survival group, it was 39%. And all of the patients who were not survived were in cardiogenic shock preoperatively. But out of the 7 patients, 3 patients had cardiogenic shock preoperatively. So although there was no significant difference between the two groups, but the result was trends towards the significance. And in both groups, the preoperative creatinine was raised. And preoperative CAG was done, and most of the cases, there were single vessel disease with a LAD, the culprit vessel, and location of VSR was, in 9 cases, it was located in the apical or anterior septum, and only in 1 cases, it was in basal or posterior septum. And concomitant CABG was done in 9 cases except 1 case. And cardiopulmonary bypass time and aortic cross-clamp time was slightly higher in the patient who were not survived, but the result was not statistically significant between the two groups. Residual VSD was identified in 1 cases in each group, and in the survival group, it was a tiny leakage which was managed postoperatively with medical management. And what is the importance is the use intervention between the survival and non-survival group. IBP was used in most cases, and from the day of development of MI to surgery, in survival group, the mean age of intervention was 15 plus minus 10 days, age range from 4 days to 35 days. And in non-survival group, it was 5 plus minus 1 days. So there was a significant difference between the two groups when the intervention is taken in the delayed phase. So with this result, I'd like to conclude that stable hemodynamics at the time of VSR is a significant predictor for survival. Patients who are able to maintain stable hemodynamics with or without mechanical circulatory support, a delayed surgical approach is preferred method for VSR. Although we have some limitation, it was a single-center retrospective study with a very small sample size with no long-term follow-up. And I would like to conclude with a message from a patient from graveyard. As time goes on, you will understand what lasts, what doesn't. Time solves most things, and what time can't solve, you have to solve yourself. And being a cardiac surgeon, sometimes we have to go beyond the time to save the life of the patient of post-MI VSR. Thank you all for your patience hearing.
Arif, a nice presentation. Do you have any question from the floor? Oh, start with Dr. Ahmad.
Thank you, Dr. Arif, for representing Bangladesh. So another speaker could not come, so he's the only one. So I want to ask you one question. I mean, what is the special technique you use for the early cases? I mean, you operated 4 cases in first week, right?
Yeah.
So what was the special technique, and what compelled you to do these cases earlier?
Because although it is, we have already shown the data, it is, we have a good survival rate if we cross the first week of a period of development of VSR, but unfortunately it is not possible to wait for this time frame despite taking all the effort of medical management and mechanical circulatory support, because patient become hemodynamically unstable and we have to go for urgent surgical repair. And in order to, because within the first week, after the acute MI, there was the inflammatory phase, and that is very difficult to identify the viable and non-viable tissue around the rupture segment of the ventricular septum. So in order to do it with the appropriate way, we need to go for an adequately large size Dacron patch with a pledgeted stitch within the RV side of the septum. And occasionally, in the very early phase, the pledgeted stitch go through the epicardium from the RV side into the inside and taken outside in the LV side. So the 3 to 4 is stitched outside the RV in the epicardium, and they give the proper strength to hold the Dacron patch into the LV side, and which will prevent the residual shunt in the postoperative period, which is the one of the case where poor prognosis, one of the cause of poor prognosis if there is a residual shunt in the postoperative case. So in order to not doing it, we need to give appropriate tightening of the patch into the septum.
Okay. Here our professor is available who operated all this case. I would like to ask one question if the one permits.
It's okay. I think we have a lot of times. I think maybe we can.
Okay.
Answer
So
if
given a second chance to people who died in this VSR, would you have done anything different? What you have done? Just my kind question. Would you please answer this question? The patient died. Some of the patient died. So
Yeah.
given a second chance to rethink.
Because of the
Sometimes because we want to learn from the mistakes. Would you have done anything different in that cases that died? That could have saved the patient.
Let me explain something, because during their early period in our center, as I have working with him, we usually not used to IABP, as I know from my guide, we were not using IABP in the earliest stage. But for the last couple of years, we are using IABP almost in most of the cases as the patient become hemodynamically unstable immediately. So I'd like to, sorry if it has anything to say.
Right, thank you. I think over the time we have done 17 to 18 VSRs.
Around 20 cases.
20 cases, because
this year.
last 1 year has been a very good, because the center has been declared as doing more VSR in Bangladesh. Now my early thinking for VSR, those days when we started. So VSR, identifying in the viability and non-viable tissue has been a problem in initial 7 days and all. See, we had no death when we did surgery after 21 days, no death. On that 4 cases that you have shown. So in that particular case, what a lesson that as you asked, we learned that after closing VSR with Dacron patches, taking deep bites and trying to take the bites in a healthy place, but then again, on the top of that, we had done SAFE procedure, SAVE, septal-anterior ventricular exclusion. You put another patch to exclude over the previous patch, so that you make a new apex, and you make that particular portion, a huge portion, infracted portion, exclude, so that the LV shape is better, and you have a double patch technique, sort of. So that we have done early days. But after IABP, as you said, has changed the total scenario. But one thing I should tell in our scenario, like in India, Bangladesh, Pakistan and all, VSR patients should not be admitted in coronary care unit, is my understanding. The cardiologist hardly can manage this sort of patient, because once patient is in shock, giving inotropes is not a good thing. Timing is important when you can you have circulatory supports and all, is more important. And this is particularly after post-MI, VSR should be, currently, to my understanding, should be admitted in surgical ICU rather than a medical CCU. Thank you.
Dr. Maharaj, please.
Yeah. Congrats, Dr. Arif, on your results. What I wanted to say, I think Dr. Jayang is partially finished. As a protocol now, what we do is, moment a patient is admitted with the diagnosis of VSR, immediately an IABP instituted. And whether to operate immediately or not is then reassessed in the next 6 hours. Now, you will not even if after instituting an IABP, you will not be able to wait for the given period for about 2 weeks, but not all of them give you a margin of waiting. And as a policy now, we moved away from VSR, just a VSR repair, a VSD repair, to a complete infarct exclusion. Because even if you've just closed the VSR, you're leaving behind a huge infarcted septum and an infarcted LV. Even surviving patients go in for progressive cardiac failure. So as a policy, we've moved away from VSR repair. We're doing infarct exclusion in all the VSRs. Thank you.
Thank you.
Thank you. For the sake of time, just move on to next speaker. Thank you very much. Dr. Chun Pan, did you come? No. Let's go to Dr. Akihito Matsushita. Are you here? Okay. Dr. Akihito Matsushita is going to talk about the outcomes of coronary artery bypass grafting in patients with end-stage renal disease and on hemodialysis. Ready when you are.
Thank you, Chairperson, and good morning, everyone. It's a great honor to be able to speak here. Today, I want to talk about outcomes of coronary artery bypass grafting in patients with end-stage renal disease on hemodialysis. I have nothing to disclose. Patients with end-stage renal disease on hemodialysis, ESRD, are high risk at cardiac surgery. Previous study showed several patients' characteristics are associated with a greater severity of disease. We often found these severe calcification of aorta or complicated disease in ESRD patients. The study aim was to evaluate the long-term results of coronary artery bypass grafting, CABG, in patients with ESRD, and moreover, we tried to identify the risk of mortality. We conducted a retrospective cohort study reviewing 771 consecutive patients who underwent CABG between 2003 and 2019. The study group consists of 159 patients with ESRD Group A and 612 patients with ESRD Group B. Mean follow-up duration was 41 months, and study endpoint was all-cause of mortality. We used Kaplan-Meier methods and Cox proportional hazard model. We lost 193 cases in study duration, and we cited these variables as predictors in Cox proportional hazard model: age, male sex, hemodialysis, diabetes, single ITA using emergent surgery, AMI, simultaneous surgery, low EF, and off-pump CABG. Patient characteristics are summarized in this table. Older patients and hyperlipidemia were frequently observed in the group A rather than in the group A. And diabetes patients were frequently observed in the group A rather than in the group B. Patient preoperative status was summarized in this table. Low EF patients were frequently observed in the group A, and over the half of patients in the group A need simultaneous surgery. Those three vessel diseases were frequently observed in the group B rather than in the group A. Operative procedures were summarized in these graphs and tables. We used single ITA for 70% in group A and bilateral ITA for 90% in the group A. And in the group B, we used single ITA for 52% and bilateral ITA for 33%. So there was a significant difference between these groups. And in the group A, we underwent simultaneous surgery for over the half of patients. 92% of these need CABG with valve surgery in the group A. And in the group B, 36% of patients need simultaneous surgery. The surgical procedure were more variety in the group B rather than in the group A. And operation time were more longer in the group A rather than in the group B. A number of distal anastomosis was 2.6 in group A and 2.9 in the group B. Operative outcomes were summarized in this table. In hospital mortality were 20 patients in the group A and 24 patients in the group B. The main cause of death was pneumonia and respiratory failure and sepsis in the group A, and low output syndrome in the group B. Pneumonia patients were frequently observed in the group A rather than in the group B. The survival rates at 1 and 3 years, 73% and 49% in the group A, 91% and 86% in the group B. It is significantly lower in the group A rather than in the group B. And the Cox proportional hazard model reveals the predictors of mortality as this table: age, hemodialysis, simultaneous surgery, low EF, and DM, and AMI. Especially hazard ratio of hemodialysis was 4.681. It was very high. In conclusion, early and long-term survival was poor in ESRD patients underwent CABG. The risk factor of all causes of mortality were hemodialysis, age, simultaneous surgery, AMI, low EF, and DM. Hemodialysis was the worst risk factor of all mortality among these risk factors in your study. That's all I have to say. Thank you for your attention.
Thank you. The floor question, please.
Thank you for your nice presentation. Sir, I have a query. Is this hemodialysis patient? Sometimes we do the fistula for the dialysis on the left side of the hands or forearm. Then did it make any problem in using IMA or because sometimes IMA flow can be compromised during dialysis in fistula. Did there add any morbidity in this patient?
Thank you for your question. Yes, it's a very interesting question. Shanto maybe still ITA flow also, I think so. But in our hospital, we don't consider about that. In our procedure, we use single ITA with RITA with left side shunt. It's not so problem. Maybe it's not so problem in our hospital. So single ITA and double SVG is a main procedure in our hospital.
If there's any more question, thank you very much.
Thank you.
Dr. Junpan, did you come? Do you hear? No. Dr. Fu Dong Fan, are you here? Dr. Ryo Nakamura? Okay. Dr. Ryo Nakamura is going to give a talk about midterm result of coronary bypass surgery in our institution. Ready when you are.
Good morning, everyone. My name is Ryo Nakamura from Wakai Medical University in Japan. Today, I'd like to show the midterm result of CABG in our hospital. Sorry for waiting. No COI. As the background of this study, bilateral versus single ITA graft at 10 years from New England Journal of Medicine, what we call ART, showed no significant difference between BITA and SITA about death from any cause at 10 years. Authoritative analysis also showed better outcome in multiple arterial grafts than single arterial graft. STS guideline recommends the use of second arterial graft. On the other hand, the rate of substance pain graft is still high because of ease to handle. So the selection of the conduit still remains a matter of debate. The objective of this study is to evaluate the midterm result after CABG in our hospital. Before this study, I introduced the grafting strategy in our hospital. The standard procedure is off-pump CABG. About 65% is off-pump. In patients with uncontrolled hemodynamics, heavily diseased coronary artery, we use on-pump. Graft inflow should be individual, and LAD should be anastomosis by ITA. Right ITA is treated with left ITA as functionally equal. We use more arterial grafts less than 80 years old, and in patients with bad aorta, we use the technique of aortic no-touch technique. We avoid to use bilateral ITA in patients with uncontrolled diabetes. From January 2002 to February 2019, we performed isolated CABG for 1,199 patients. We do cases and LAD revascularization other than ITA graft was excluded, and 1,146 cases were enrolled in this study. We performed 2 analyses. The first analysis is retrospective analysis of these cases divided in 3 groups. Group B is bilateral ITA plus other grafts. Group S plus A is single ITA plus other arterial graft. Group S plus B is single ITA plus surface pain grafts. The second analysis is propensity score matching analysis comparing bilateral ITA and single ITA and comparing multiple arterial graft and single arterial graft. The first analysis is retrospective analysis divided in 3 groups. This is the results of the patient's characteristics. It's significant to notice group S plus B include higher age, higher rate of diabetes, hemodialysis, and emergent cases, and low ejection fraction. On the other hand, group B include higher rate of male and disease out defined by calcification or plaque in CT and intraoperative ultrasound. This is the result of the coronary regions. Triple vessel disease is occupied more than 50%, and LMT coronary regions is occupied about 25% in all groups. This is the early results. The average distal anastomosis was around 3. The 30-day mortality is around 1%. Hospital death is up 1 to 2%, and perioperative cerebral infarction and deep sternal infection is up to 1%. There are not any significant difference in 3 groups. This is a result of the patency of each graft. Mean graft evaluation period was 3.5 years, and more than 98% of ITA to LAD was patent, and more than 90% graft anastomosis other than LAD territory was also patent. This is a mid to long-term result of survival rate from all-cause death and cardiac death. Group S plus B, the expected 10-year survival of group S plus B is 65%. This is the lowest in the 3 groups. Survival rate from cardiac death, not any significant difference in these in 3 groups. So summarizing the first analysis, bilateral ITA or single ITA plus arterial graft have a better outcome than single ITA plus surface pain graft, although there are many differences in patient's background. No difference in early operative results. The second analysis is propensity score matching analysis. Adjusting the patient's background, we choose these matching factors. The first comparison is group B versus group S plus A and S plus B. This comparison means which is better, BITA or SITA. The second comparison is group B and group S plus A versus group S plus B. This comparison means which is better, multiple arterial graft or single arterial graft. Which is better, BITA or SITA. The patient number was 321, and the average age was 67 years old. All other factors are adjusted. This is the target coronary region. Indeed, in the 2 groups, there are not any difference. This is the early results. The average distal anastomosis was around 3. 30-day mortality, hospital death, perioperative cerebral infarction, deep sternal wound infection. These factors, any not any difference in two groups. The expected 10-year survival from all-cause death was 83% in bilateral group and 74% in single ITA with no significant difference. Survival rate from cardiac death are almost the same in two groups. The second comparison, which is better, multiple arterial graft or single arterial graft. The patient number is 251. The average age was 71 years old. Other factors are adjusted. Target coronary regions are almost the same in two groups. The average distal anastomosis was around 3, and other factors are almost the same in two groups. The expected 10-year survival of multiple arterial group was 83% and 69% in single arterial graft. This result has the potential of having a better outcome in multiple arterial graft. Survival rate from cardiac death are almost the same in two groups. So summarizing the second comparison, there are not any significant difference between BITA and SITA, but there have the possibility of reduction in all-cause mortality with multiple arterial graft. These results are very similar to ARTERIAL. There are no difference in early operative result in two analyses. This is the conclusion and repetition. Early and midterm results in our hospital are compatible with other studies. Multiple arterial graft has a potential of better long-term results. Thank you for your attention.
Thank you very much. Question from the floor? Yes, thank you.
Very nice presentation and good analysis. We have the same experience, but we did analysis until 16 years, and we found that there are about 8% difference in mortality at 8 and at 16 years between total arterial revascularization patients and patients with single mammary artery and venous grafts. This first. Second, also we did study about patency of grafts after 10 years. And we found that in first 4-5 years, there are no difference between patency of arterial and venous grafts. Maybe venous grafts are better. But after 4-6 years, patency of arterial grafts are much better. My question is, if you did any analysis about survival rate between these three groups and expectancy of life in your country, with patients who did not have any revascularization?
Can I ask one simple question, please? I'm sorry.
So, yeah. If you did any analysis about survival rate of your cohort of patients with expectancy of life of patients in your country, of citizens in your country. Let's say expectancy of life is about 80 to 84 years old. So these patients were operated about 64, 66 years old. What is differences between people who did not have had any operations and these patients?
I'm sorry, but I can't.
So you didn't compare patients who were operated with patients who were not operated? Probably. Because Floyd Loop many years ago did such a comparison, and he found that patient who has mammary artery on LAD has life expectancy more than people who has no any operations. So mammary artery on LAD is prolonging life of patients.
Yeah, your talk was so nice and so elaborate regarding your calculations of, segregating the patients. I really enjoyed your talk. The question comes, as George was saying, Gregory was saying that you segregating, what is the life expectancy? How long the people live in Japan? And then you do the surgery. Say, suppose, I will not take bilateral internal mammary artery for a patient of 90 years of old. 90. So that is important. So that is why. My question was a little different. As you said, multiple arterial graft. So other than internal mammary artery, you have taken right internal mammary, left internal mammary. Did you take radial artery?
Sorry?
Radial artery?
Yeah.
And did you anastomose radial artery with internal mammary artery?
No.
So radial artery to the proximal part with the aorta, isn't it?
Proximal aorta.
The people does radial artery anastomose with the internal mammary artery. I will ask the chairperson. To me, as a surgeon, is not very easy. People does it, definitely, because the thickness of the internal mammary artery and the radial artery is double or triple size of the internal mammary artery.
Mm-hmm.
Definitely it can be done. But to me, I always very comfortable with the similar thickness of the conduits, the Lima and Rima Y graft. Though we do in situ grafts, Rima to LAD and Lima to OM, or Lima Rima Y, and we do sequential grafts, but putting radial artery not in the aorta, but on the internal mammary artery, to my understanding, I have never done it. To my understanding, that radial artery thickness is so big, how can it match with the internal mammary artery? Maybe it is done. People does it definitely. But if anybody can answer this question in the house.
Sorry.
To answer to your questions, I'm using sometimes Y graft mammary artery with radial artery and anastomosis, Y anastomosis. But only in these cases, especially in women who has a very thin wall of radial artery and small radial artery, and they have small coronary arteries. So in this situation, you can use. Otherwise, if you are doing T or Y graft with radial artery, you will have any distortion of the anastomosis, and risk of occlusion is very high. Usually, I'm doing, if I'm using radial artery on the left wall, I'm doing central anastomosis on aorta with 7/0 like you do. The same situation is with right coronary artery. But I prefer to do right mammary artery through transverse sinus on lateral wall, and left mammary artery to the anterior wall, diagonal and LAD. This is the best choice in my opinion.
Thank you. I think Japanese don't use radio a lot. I think they use bilateral ITA more. Radiology don't have a frequent use. And in his literature, he said that if the age of patient is over 70, you try to avoid using bilateral ITA, right? Do you think that in the group of the use, the IMA and vein seems to have a low quality? I mean, morbidity, mortality is higher a bit because of the risk factor or something. But do you think that if you pay more time a bit to use more arterial graft for this group of patients, can make the result better or not?
I think
It seems to be. I don't know.
better.
Yeah, thank you. Nice presentation. Thank you very much. I think if the Dr. Chun Pan and Dr. Fu Dong Fan is not here, so there's going to be the last speakers. The last speaker is Dr. Takahiro Oseki. He's going to give a talk about usefulness of free RITA for left-sided complete revascularization with bilateral internal thoracic arteries. Please start.
Good afternoon, everyone. I will present about usefulness of free lima. There is no COI. Currently, it is recommended to use more arterial grafts for CABG, especially using bilateral IMA may make long-term results better than using single IMA. When we use bilateral IMA, in situ lima to LAD is gold standard, and in situ lima to LAD is comparable to that. But it is controversial in how to use the other IMA. We examine the post-operative result of free lima anastomosis by two central anastomosis methods, piggyback anastomosis and fallback anastomosis. Of the patients who underwent isolated CABG at our hospital, 627 patients had complete revascularization of the left coronary artery using bilateral IMA. After we excluded patients who had composite graft, we divided them to three groups. 343 patients had free lima, 101 patients had in situ lima, and 183 patients had in situ lima, based on graft to the circumflex region. In the free lima group, two types of proximal anastomosis, piggyback anastomosis and fallback anastomosis, were performed. The piggyback anastomosis is a procedure performed when there is an anastomosis to right coronary. First, after distal anastomosis to right coronary, make the orifice about 5 mm diameter at ascending aorta, and leaving the proximal end of the graft about 5 mm. It is anastomosed side by side on the ascending aorta. Next, cut back from proximal end of the right coronary graft to just above the orifice. In the same way, cut back the proximal end of the free lima. After that, anastomose proximal end of both grafts. Fallback anastomosis is an anastomosis performed when there is only free lima for proximal anastomosis. First, leaving proximal end of the free lima about 5 mm, anastomose with the ascending aorta side by side. In this case, the orifice is made about 5 mm diameter too. Next, cut back the proximal end just above the orifice. Fold back the dorsal wall and suture the lead just above the orifice. This is a CT scan at 5 years after operation of the case that performed piggyback anastomosis. In this case, this venous vein graft was anastomosed to right coronary. You can see that the orifice is large and the diameter of free lima is sufficient, and good patency can be seen. Next is patient's background in baseline. In all groups, men are majority, and hypertension and dyslipidemia have a high proportion. There is no significant difference in preoperative patients' characteristics, including percentage of low heart function and emergency surgery. It is distribution of the graft target. Target of free lima has many variations. There is an advantage in terms of freedom of graft design, especially for sequential with long anastomosis distance that cannot be achieved with in situ graft. On the other hand, in situ lima has few variations in design and can target only a branch near the left arterial appendage. In situ lima has relatively many variations at a glance, but less than 2 anastomosis the target of most cases is only one target. It is easier to reach the peripheral area than in situ lima, but it's not as free as free lima. Even when comparing the total number of anastomosis, it can be seen that the number of anastomosis tends to be larger in the free lima group than in the other two groups. Because it depends on the number of targets that need anastomosis, it cannot say directly, but high degree of freedom or free lima seems to have, seems to have influenced this result. It is post-op complications, early post-op complications were not significantly different. The mediastinitis was also low, about 1% each. In the long-term period, angina and the PCI rate was significantly higher in the in situ lima group. As a result, were not significantly different. It is survival rate from all causes of death. It is not significantly different between the three groups at 5 and 10 years. Regarding the graft patency rate, the 5-year patency rate was as high as 95.6% in the free lima group. And the free lima group had a significantly higher patency rate than the in situ lima group. Although there was no significant difference compared to in situ lima, free lima tends to have a higher patency rate. Looking at the shape of the graph, the patency rate is not much different in the early post-op period, and after several years, the in situ group declines while free lima group keep a high patency rate. Rather than a perioperative technical issue, it seems that thinning of the string in a few years has led to the result. For proximal anastomosis, piggyback anastomosis was performed in 313 cases, and fallback anastomosis was performed in 30 cases. Saphenous vein graft is the most commonly used graft for right coronary, with 298 cases, and the radial with 14 cases, and the free GA is 1 case. In the proximal anastomosis, the inflow is the same as that of the right coronary graft. Therefore, there is a concern about collapsing due to the occlusion of the right coronary graft. Although saphenous vein graft is occlusion at 24 patients, it is only 1 patient that both grafts occurred. This says that the patency of graft to right coronary is hardly affected to free lima patency. By the way, the outcome of bypass surgery is controversial in diabetic patients. The paper based on our data discusses a case of diabetic patients who underwent complete revascularization of the left coronary artery with bilateral IMA. As a result, the anastomosis between free lima and the circumflex branch showed a high patency rate of 90.3 in 4 years. Compared between diabetic group and non-diabetic group, the patency rate was significantly higher in the diabetic group, which means that good long-term result can be expected for even diabetic patients. Post-op mediastinitis did not differ significantly between diabetic group and non-diabetic group. For lima graft design, it includes in situ composite graft as a free graft and direct proximal anastomosis. Composite grafts include Y composite and V composite. In previous reports, free lima tends to have a higher patency rate compared to in situ lima, but there was no significant difference. But in this study, for lima had better patency significantly. In situ lima has a disadvantage that there are restrictions on design due to competition and length restrictions. But free lima is direct aorta coronary anastomosis, so that can solve competition, and it can make various designs. In addition, the possibility of occlusion due to the same inflow by graft to right coronary is small because of the piggyback anastomosis. It is conclusion. Free lima using piggyback and fallback anastomosis has a significantly higher patency rate than in situ lima. Free lima makes various design possible, and it is useful for complete revascularization of the left coronary artery. Free lima can be expected to give good long-term result even in diabetic patients. Thank you for attention.
Thank you for very beautiful presentation. I have a question, please.
Yeah. Thank you for your nice presentation. It's a very interesting presentation. Piggyback anastomosis with the RITA. But I'm curious about one thing. Most of the piggybacks are, if I'm not getting wrong, is done on the saphenous vein graft, right?
Yes.
Yes. But why you think it didn't affect your long-term patency? Because proximal segment is mostly the vein graft, and then distal part is only radial graft.
Yes.
So why do you think it didn't affect the long-term patency of this graft? Vein graft tends to get patent shorter period, but why it didn't affect your result?
I guess we anastomose at aorta wall, first vein region, and above that, RITA region, and a little region is vein, and most of that is RITA. So I guess it hardly affected.
So actually, my question is from the beginning of this technique. What is the principle in surgeon's mind that this technique is going to work? What is the reason behind what you're doing this technique from the beginning? What do you expect actually from this technique from the beginning?
I'm not sure that because my boss that
I know.
technique, yes.
You see, you have used the lima at the same setting. You could have done if you say the length is shorter, you could have anastomose with the lima graft to make a Y and put it into the left side. But you rather prefer to put the proximal on the vein graft. Why is that? Because the vein graft always tend to the process of atherosclerosis starts very early, sometimes as early as 1 or 2 months. So why you preferred the vein graft to do the piggy or not doing the arterial graft as a Y with the lima? That is also a very good option.
Well,
Do you?
Can I answer his question?
yeah.
Professor.
I think best thing is doing right coronary artery grafting. Most of the right coronary artery, if you graft, has got a diffuse disease and calcified, very thick wall. So doing this technique with the internal mammary artery, free internal mammary artery, RITA, is not very feasible. In that particular case, if you do with the vein graft, which has a bigger lumen and easy to graft, and then on the top of that, you put RIMA. That is the basic principle. Sometimes the internal mammary artery is so thin, and as I said, the thickness matching is very important. So in the right mammary artery is so thick, and you put that disease portion when the total it is thickness. So the anastomosis may not be good. So in that particular case, I understand. Answering to your question. That is why this technique has come. And on the more of that, if you choose PDA, posterior descending artery, that has a very good thickness. So I always prefer grafting PDA. In 90%, 95% cases, I graft PDA rather than RCA to match the conduit and the arterial thickness.
And also, I think maybe the surgeon want to leave lima to LED isolated. They don't want, and also the flow from direct from the aorta through the vein can make less competitive flow through the RITA to the lateral wall. If the degree of stenosis is not high, maybe there's some reason behind that, I think. Because the flow is high from the aorta through the vein, so less competitive flow, I mean.
Yeah.
Am I say it right?
Yeah, right. Exactly.
Is there any comment or suggestion or question? We have 3 or more, 4 or 5 minutes. Thank you.
I will ask to ask, what is specific indication for this kind of anastomosis? If you have any, maybe calcified aorta, maybe another not to do two anastomosis or to the aorta. What is a specific indication for such kind of anastomosis?
Yeah, of course, we exclude calcification aorta and aorta that we don't have to touch. So that case, we do a crossover inside RITA to circumflex and inside RITA to LAD. And yes, that case, we don't touch aorta.
You mean the question is how you select the patient to do this kind of procedure? Which case you select to use this procedure? Every case or?
Mostly we do that technique. And about rare case, such young people and or right coronary stenosis is very hard. So that time we use inside to GA, but it is a rare case. We almost all cases almost all cases we do that technique.
So in the case that you proximal anastomosis to the aorta in your institution, you use device or you use partial clamp? When you do proximal anastomosis to the aorta, you use device?
Yes.
I mean, like an enclosed tool or?
Yes, enclosed tool.
Or partial clamp?
No partial clamp, we use
You use no clamp, just device?
Yes.
Okay. Maybe that's the reason. You can use almost every case, I think. Thank you very much for a great presentation for everyone, but I think more important is the audience. Thank you very much. See you next time.